Of that 85% that have pituitary dependent, only 15% of those dogs will have a macroadenoma. So the vast majority of dogs that come in with Cushing's disease are going to have a pituitary microadenoma.
Hey everybody, and welcome back to Vetfolio Voice. This episode is sponsored by DECRA, and in it I was joined by Dr. Patty Lathan and Dr. Alex Betson to talk about Cushing's disease. You know, we usually call Addison's disease the great pretender, but sometimes I feel like Cushing's really deserves that title too. Cushing's is more than capable of throwing us for a loop and being downright confusing. I know that has certainly been my experience in a number of cases. So of course, I was thrilled to sit down with these two brilliant minds and dig into some of the real-life challenges we face when we're diagnosing and managing Cushing's disease. Dr. Patty Lathan has been on the podcast a few times before, and we always have great conversations. This was certainly no exception. She just has such a practical approach that somehow it makes sense in my brain. And I loved having Dr. Alex Betson as part of the conversation as well. He brought valuable insight not only from his own experience, but also from the number of questions he fields from veterinarians calling in about Cushing's cases. He really helped shed some light on some of the most common stumbling blocks we face in practice and shared his guidance to help make management maybe just a little bit easier. Dr. Patty Lathan is a professor of small animal internal medicine at the Department of Clinical Sciences at Louisiana State University. She earned her veterinary medical degree from the University of Pennsylvania and then completed an internship at Mississippi State University and a residency in small animal internal medicine at Purdue University. Dr. Lathan specializes in endocrinology, specifically adrenal function testing, diabetes mellitus, and the mitigation of side effects of glucocorticoids. She's currently past president of the Society for Comparative Endocrinology. Dr. Alex Betson is originally from Kansas City and completed his bachelor degree in biology at Kansas State University. He received his Doctor of Veterinary Medicine degree from Kansas State University. After vet school, Dr. Betson completed a one-year small animal rotating internship. After completion of his internship, Dr. Betson worked at two large and busy small animal clinics in Houston, Texas. Dr. Betson was able to develop his surgical and internal medicine skills before moving back to the Kansas City area to work as chief of staff at a small animal practice. Dr. Betson joined DECRA in 2020 and provides technical and professional support for companion animal and equine products. He spends his free time with his wife, 3 children, and a dog, and is a member of the AVMA, AAIV, and KCVMA. All right, let's go ahead and talk Cushing's.
In the age of Dr. Google and conflicting influencer advice, it's important to follow the evidence. That's why the NAVC publishes free veterinary journals for every member of the veterinary healthcare team. Subscribe to Today's Veterinary Practice and Today's Veterinary Nurse for evidence-based clinical insights. Or check out Today's Veterinary Business for practice management guidance and deep dives on the latest industry trends. Visit navc.com and hit the Publications tab to learn more and subscribe today.
Well, for this episode, I am joined once again by Dr. Patty Lathan and also by Dr. Alex Betson. We're going to talk about Cushing's disease, and we're going to try really, really hard to stay within our confines of our time limit and see how it goes. Thank you both for joining me.
Thanks for having me.
Thank you so much.
Absolutely. Absolutely. So I want to talk about clinical signs of Cushing's disease. I mean, we have our classical clinical signs we think of, but there's also some more subtle clinical signs. And so I'm wondering if you can give us some insights on maybe some things that you have seen associated with Cushing's disease that it was, maybe you didn't put it together that it was a part of Cushing's disease until Cushing's was under control, or, just kind of surprised you as that being a clinical sign?
Yeah, that's a really good question. Certainly most of the patients that we end up diagnosing with Cushing's come in for, drinking a lot, peeing a lot, accidents, et cetera. But I think over the years, one of the things I've seen in these dogs is the amazing turnaround in activity and personality once we start treating them. I've had multiple owners that have told me after we started treating their, 10 to 15, or actually even one of them was 17-year-old dogs, that a week or 2 weeks into treatment, the dogs were acting more themselves, playing with toys more. I mean, these are old dogs, right? And how many of us don't have older dogs that have stopped playing with toys, which we assume is just part of them getting older. But then some of these old dogs with Cushing's hadn't been playing with toys for a year, and then the owners were like, oh my God, this dog is now playing with toys. Or one of my friends had a dog with Cushing's that actually went on walks with us every day. And a couple things that she did. First of all, when we started treating her, she started going from just right next to us, walking along, like a typical dog, to suddenly exploring, the mailboxes and the grass and such. And when I asked her specifically what she thought changed the biggest in that dog, she was like, I hate to anthropomorphize, but I feel like she was depressed before. And it's super interesting. You look at people that have Cushing's, and I think 2/3 of them or more have major mental health issues, to the point where a lot of them are actually relieved to have their Cushing's diagnosed because they realize that there's an underlying cause. So it's not shocking that we see this in dogs, but it's not something 15 years ago that I would have been like, oh yeah, obviously that's due to Cushing's.
Yeah, no, that makes sense. I've had that experience as well. I can think of one patient in particular that, blood work just kept suggesting Cushing's, and there were some concerning findings that, we could no longer just kind of sit there and say, we'll just keep an eye on it. So we did a low-dose dex test. She came back Cushing, and we treated. And the owner, I remember telling me, she's acting like a puppy now. She feels so much better. It's a complete personality change. And I remember being surprised by that as well, because behavior change isn't necessarily something we classically associate with Cushing's disease.
Yeah, super interesting. We see all these patients that we put on steroids for various things, especially in internal medicine, all these immune-mediated diseases. Dealing with these Cushing's patients after we start treating them with trilostane has made me realize how these dogs that we're treating long-term with steroids probably feel as well, and how happy the owners are when we finally get them off, not just because they're not drinking and peeing all the time, because they literally are back to themselves.
Yeah, gosh, I didn't even think about that, but that makes sense. Definitely something to keep in mind when we have these long courses like you're talking about. Alex, anything you want to add to that? Weird clinical signs that you have seen yourself or maybe heard other veterinarians report?
Yeah, with my role here at DECRA, fielding phone calls from anybody that has questions about any of the DECRA products, I'd like to tell people that call in, you guys are calling to talk to us when things are not easy, not when things are easy. It's going to be your weirder cases, more than likely, where you're calling in to talk to us. And so there are some cases where calcinosis cutis was the only sign that the dog came in with Cushing's disease, or maybe only derm signs are the only signs that came in. So recurrent skin infections, that sort of thing. So the behavioral stuff is definitely something that we still get occasionally too, where they will let us know they're acting more like themselves or more like they're used to. But we still do get quite a few calls or consults when people are stumped a little bit and not quite sure where to go with some of the recurrent skin infections, or calcinosis cutis is the presenting complaint. It's not very common that we get those, but probably overrepresented because they're calling us when things are unusual.
And I'm curious, when you're talking about calcinosis cutis as the primary complaint, do these cases typically have blood work findings that correlate with Cushing's, or they're like everything else looks normal and then this dog has calcinosis cutis?
That's really good. I haven't seen anything published on anything like that. Anecdotally, from the kind of calls that we get, I will tell you that once you start having one odd presentation of Cushing's, everything else about it tends to be kind of odd. So like the alkaline phosphatase is elevated in 85% of dogs with Cushing's disease. But if it's going to not be elevated, it's probably going to not be elevated in the 6-year-old dog, which is already a little too young for Cushing's disease, or the 13-year-old dog that's coming in with just calcinosis cutis. So once we have sort of one odd presentation or one odd aspect of a presentation for Cushing's case, it seems like those cases often come with more than one odd aspect to them, whether it be just lacking the more common clinical signs and some of the more common lab findings that we would expect on a routine CBC Chem UA.
Yes, and those can get frustrating because some of our classical signs that we look for, the PUPD and things like this, they rely a lot on what the owners are reporting. And I've found that can be unreliable at times because sometimes these changes are subtle, they're gradual, and so the owners kind of adjust and don't realize there's an abnormality there until we treat it.
For treating calcinosis cutis, we know that trilostane has a relatively short half-life in the vast majority of dogs. That said, each dog metabolizes trilostane and absorbs it on a very individual basis. So the vast majority of dogs will do quite well on once daily trilostane, and that is the labeled recommendation for trilostane, is to start at once daily dosing. There are some cases where we have to go to twice daily dosing. In those dogs, the calcinosis cutis dogs and the diabetic Cushingoid dogs are the ones where I will usually talk more about going to twice daily. The reason being is that we're going strictly off the pharmacokinetics of trilostane in the average dog. And we know if you give a dog trilostane once daily, there's a reasonable chance that there's not going to be much trilostane left in the middle of the night. For most Cushingoid patients, that's probably not going to matter. If they're not waking the pet owner up in the middle of the night and they're happy at home and the dog is doing well, that may be okay for a lot of pet owners. But for those calcinosis cutis dogs and diabetic Cushingoid dogs, we kind of need the cortisol levels to be a little bit more maintained throughout the day. And so I will always start or consider twice daily dosing in those dogs to get a more even daily cortisol level. Topical DMSO is also really helpful. I do encourage folks to reach out to their local dermatologist because there is a ramp up. You can't just start slathering DMSO all over the dog. You have to start in small patches and work your way up. And then anything I can use for topical therapy to soothe. Some of these guys can be really uncomfortable. So you're not going to probably be reaching for an NSAID or something like that, but some type of oral analgesic can be really helpful for these guys. In the initial parts, some of these guys may benefit from a low potency topical steroid to relieve a little bit of the inflammation. That can be fuel on the fire, so you've got to be very, very careful with that. Oral antibiotics when necessary for some of those deep pyodermas. And then, unfortunately, it's just kind of a waiting game, and it can take many months for them to resolve. And often, the outermost lesions will be totally resolved, but there'll be some change that you can feel in the subcutis with some kind of calcification within the subcutis. But that typically I try to get very aggressive with trilostane therapy early on to get these guys going. Really want them to be finely tuned in terms of monitoring and have that appropriate trilostane dose dialed in. And then it's about DMSO, oral antibiotics, and pain relievers until their skin is under much better control.
Yeah, that's a really good point about twice daily. I found that my patients just get regulated much faster. You know, I started out using once daily dosing back in the day, and I was like, well, most of the patients are clinically controlled this way. But what I found, what's super interesting, is that when I moved to the twice daily dosing, which I did for a study, I found out that I often hit the right dose like the first time I tried. And even though the twice daily dosing, you know, we all know that 10 milligrams twice a day of trilostane cost more than 20 milligrams once a day. But then when I acknowledge the fact that a lot of times when I start once daily, I have to keep increasing the dose because I haven't quite gotten the clinical science under control. Every time you do that monitoring, it costs more money. So I feel like the owners are happy, the patients are happier, and it may end up being a wash financially if we start out twice daily, which, as you said, gets them better under control with calcinosis cutis. One thing I did want to point out is when you start treating dogs with Cushing's with trilostane, you do decrease that anti-inflammatory effect. So making sure that vets warn the owners that actually initially the itchiness of the calcinosis cutis might actually get worse initially as the anti-inflammatory effect goes away. So owners don't freak out about that and think that the trilostane is doing something bad. I just tell them they're self-medicating for their itchiness and you took it away.
All of that's really helpful because, calcinosis cutis is fortunately not one of those things that generally is our number one sign we're seeing in dogs with Cushing's disease. So yeah, I can tell you I would assume like, yes, we need to get the Cushing's under control in order to treat this, but the other recommendations you had and considerations for them getting more itchy, all of those things would throw me for a loop in that case scenario. So yeah, I'm glad that we went back and revisited calcinosis cutis because that is kind of one of those presentations for Cushing's that you just don't want to see. It just kind of throws a monkey wrench in things and complicates things.
Yeah, and that applies to any inflammatory lesion the dog has. I don't see it often, but it definitely, dogs that have derm problems may not be itchy initially when they're treated, or before they're treated, then they get itchy just because the cortisol goes away.
Yeah, that makes sense. I mean, we would put them on prednisone if they were itchy, and now we're taking the equivalent of that away from them. Poor things. And then that, I don't know. I hope I don't have to manage those cases too often, because that sounds miserable, because then we can't, like you said, we have to be really, really cautious with the topical steroids and, having a hard time keeping them comfortable that way. And NSAIDs are probably not the best choice right at that moment. So yeah, those poor dogs. I mean, it's a complicated enough disease process as it is. Throwing that one in there just, makes things tough.
And I know Dr. Lathan maybe doesn't see as much of this as we do here at DECRA, but we get quite a few calls of things that I would say are prednisone responsive or steroid responsive that rear their ugly head after starting trilostane. So
tell us more about that.
The classic example is atopy. So these are dogs that maybe were just kind of smoldering cushingoid dogs and went through an entire allergic season without any flares. And everyone had sort of forgotten, oh yeah, every May my dog does often have otitis or itching along the belly with secondary skin infections. And then we started trilostane maybe in the fall. And then spring rolls around again and suddenly their atopy is back. Well, it was always there. It's just that their Cushing's disease was masking it. There are occasionally times where we'll use their Cushing's disease to our advantage and let their Cushing's disease manage a comorbidity. So as an example, if I have an immune-mediated disease state and the dog has Cushing's disease, I may choose not to treat their Cushing's disease to help me manage their immune-mediated disease state. And I never want people to think, hey, I've got a dog on trilostane and I need to give a little bit of pred to get through this thing. Just stop the trilostane. Let the dog's own cortisol levels treat the atopy. You can always pick back up the trilostane in a couple of weeks after the allergic flare has gone by. And yeah, you'll have a little PUPD or a little polyphagia for a little bit, but you're going to save the cost on the trilostane, number one, and the expense of the prednisone and some of the other therapies that we have to do. So if we can let their Cushing's disease manage their comorbidity, that can often be really helpful.
Yeah, gosh, it seems so obvious when you say it, but like hearing it, it's not something that has been top of mind for me. I feel like that's a really good segue into talking about comorbidities. Can you guys talk a little bit about how you approach diagnosing, working up cushingoid dogs in the face of different comorbidities?
Yeah, I agree. Alex had a really, really good point about discontinuing the trilostane when they have an inflammatory disease. The other thing is, you're right, this segues right into it, is that if you've got a dog who presents to you because of decreased appetite and some other signs, vomiting, diarrhea, etc., but you're staring at that dog and you're like, oh my God, this dog totally has Cushing's. I know this dog has Cushing's, but at the same time, the dog's not eating and the dog's vomiting. I think it's important for vets to understand that even though that dog has Cushing's or high cortisol concentrations do not cause vomiting or anorexia. Now, a macroadenoma, which only occurs in about 10 to 20% of the pituitary-dependent Cushing's dogs, that can cause a decreased appetite and behavior change, but it does not cause vomiting. So if you've got a patient who has a decreased appetite and vomiting, it's super important to get the underlying disease under control before testing for Cushing's for two reasons. Number one, the Cushing's is not causing vomiting and decreased appetite. And number two, if you test a dog for Cushing's, you're measuring cortisol concentrations. If you test them while they have some other clinical illness, then that clinical illness causes an increase in cortisol just due to stress, and you can absolutely get a false positive on it. So I think that was the first point, is when you've got a sick dog, that illness per se, the vomiting and decreased appetite, is not due to Cushing's or high cortisol. Man, the other diseases, we can go on for a long time about concurrent, say, diabetes. Oh man, Cushing's and diabetes can occur in lots and lots of different ways, but one of the most common ones I see are dogs that have uncontrolled diabetes that we're questioning whether they also have Cushing's at the same time. This uncontrolled diabetes can present multiple different ways. One is maybe the dog's glucose is just super difficult to get under control. You keep going up and up on the insulin dose and the glucose just doesn't budge. Alternatively, uncontrolled diabetes could be that the dog's glucoses are responding to the insulin sometimes, but other times not. So it seems that Cushing's causes an increase in glycemic variability, meaning giving the same dose of insulin once or twice daily every day doesn't result in the same decrease of glucose. So one day the glucoses may look pretty controlled. They're between 100 and 350. And then the next day, all the glucose are above 500. And then the next day, the glucose are going between 60 and 473. So we see that with Cushing's as well, so it's almost sometimes like it causes a shorter duration of activity of insulin. The other thing we'll see Cushing's cause is that you'll have a dog who actually their glucoses look decently controlled. Back in the day, we used to tell people a well-controlled diabetic has glucose between 100 and 250. And yeah, we're all rolling our eyes on that. I don't think the people will be able to see us rolling our eyes, but that's what we were kind of taught. Yet all of us are like, when do we actually get a dog controlled between 100 and 250 throughout the day? We don't. Most of the time, if I've got a dog that goes between 80 and 350 throughout the day, lots of times those dogs are clinically controlled. Yet we'll see some dogs that are between 80 and 350. I mean, occasionally, yes, some of them we'll see between 80 and 350 where we can work better on the insulin. But then there are other dogs where that's the best I can get, but they just seem so much disproportionately more PUPD than that glycemic control would suggest. So I've had some of those where I'm like, well, you're not super poorly controlled as far as your glucoses, but you're still super PUPD. And sometimes when I check it, their specific gravity is like less than 1020. Most diabetics are above 1030 because of the fact that they have all this glucosuria. But some cushingoids will have specific gravities less than 1020. Not all of them. Some of them will still have specific gravities higher, but when they're diabetic. But you'll have some cushingoid diabetics with specific gravity of 10 below 1020, and that's a trigger for me to think, oh, this could totally be Cushing's. It's not all of them, but some of them. And in those cases, all of those cases are going to push us towards looking at Cushing's.
I feel like there were so many pearls there that I just took away of things to look for to solve that puzzle, because like you said, those diseases go hand in hand and they can just make things really complicated. Alex, I'll stop there. Let me hear your thoughts on comorbidities and some of the things that you're seeing.
Yeah, a lot of the questions that come to our team are very similar to what Patty just outlined, where they are a diabetic and now there's a question about whether or not they need to be worked up for Cushing's disease. We'll see it the other way too, and those seem to come to us with some regularity as well, where they were a Cushingnoid dog and then for whatever reason, maybe their signs weren't as well controlled on that trilostane dose, but at any rate, they end up positive with the glucosuria and a high blood sugar and have diabetes. That seems to happen within the first month or two of starting trilostane, oddly enough. It just seems to kind of often coincide with it. There's nothing about the metabolism or excretion of trilostane that would cause diabetes. It's just that they were on the cusp of becoming diabetic. And if we just had tabled the Cushing's diagnosis another 2 months, we would have first had to diagnose the diabetes that was coming regardless, and then worry about the Cushing's disease. So we do see it happen the other way sometimes too, where they were probably a smoldering, or a lot of the times that we will see those is on their initial workup for Cushing's disease, they have a blood sugar like 160, not enough to make you think much about it, but enough where looking back with hindsight, you kind of say, boy, 160 glucose in a dog probably is not, they were probably smoldering diabetic at that time too. We'll also see some like biliary mucoceles are also very common with Cushing's disease due to the changes in lipid metabolism and architecture of the liver associated with their endocrine hepatopathy. So that's another thing that we kind of have our eyes open for. That's another one of those things where they could be cruising along and doing pretty well, and then we start trilostane and remove some of the anti-inflammatory effects of their cortisol level, and suddenly the mucocele that was sort of smoldering there is now a little bit worse or there. So our team is happy to talk to folks when they have questions about that. Some of the other comorbidities that we have, renal disease gets kind of tough. We'll have some dogs that have renal disease. Renal disease kind of goes back to that thought of, why don't we let this dog be an uncontrolled Cushingoid dog to manage their renal disease, because it'll help diurese their kidneys as well as help with appetite. Those get to be a little bit of quality of life situations, and I'm never going to argue with a veterinarian or pet owner that says my dog's quality of life is better on trilostane than not. If they're doing well on it and they're happy with it, great. That's going to be the first thing that I take off of a kidney dog when they're not eating well or feeling well or anything like that. So there's a few other things that are in there that we'll see occasionally, but the diabetes, the biliary mucoceles are probably going to be the big ones. Occasionally we'll get questions about Cushing's disease causing a hypercoagulable state. There is a lot of discussion about really trying to tightly regulate Cushing's dogs and reduce their likelihood of a thrombotic event. There's been nothing published that shows that controlling their Cushing's disease prevents a thrombotic event. So I don't tend to, and at the call center, we really try to focus on managing their comorbidity, managing their Cushing's disease to help manage their comorbidity, or managing their Cushing's disease to help control their clinical signs. We're not in the business of trying to prevent something that has not been published to show that treatment with trilostane prevents thrombotic events. Have I recommended Plavix occasionally? Because you'll sometimes get these Cushing's dogs that come in with a platelet count of 800,000, or I think I've seen 1.1 million at 1.2. Wow. And some of those dogs probably should be on Plavix. But outside of that, I don't tend to worry too much about their thrombotic events. And unfortunately, that's due to their underlying disease more than their treatment. And there's just not much we can do to manage it.
That's really interesting. You know, I came out of vet school being so worried about all these pulmonary thromboembolisms or thromboemboli that we were going to see in our Cushing's patients, and they're just not that common. I had, based on all the research that's been on it, you would think that they're occurring all the time, but honestly, the patients that we see with PTEs, or, you know, we'll see the equivalent of saddle thrombus in a dog sometimes, they are generally undiagnosed Cushing's dogs. And once I start treating them, I don't see the problems. I mean, obviously, that's not going to be all of them, but the majority of them are untreated Cushingoids.
Sometimes I've wondered about like mini strokes, TIAs, with hypercoagulable states, and seeing neurologic signs. And I'm curious to know your thoughts. Maybe if we have neurologic signs, are we talking about pituitary issues, or could they possibly be throwing clots or something along those lines? Which also segues into my next question, which, yeah, we're doing great with these segues here, of distinguishing between adrenal masses versus pituitary masses. I mean, because I'm thinking in this neurologic question, if we are seeing that and we don't know if it's pituitary or adrenal, how important is that to distinguish those two? So I'm going to wrap both of those questions together and then throw those at you.
So when it comes, that is a question that at DECRA, a call center, we get with some regularity as well. I will tell you, I'm coming at this from a general practitioner standpoint. And so I understand the value of differentiating. Trilostane is labeled for adrenal dependent or pituitary, and there is nothing on the package insert for trilostane that would require you to distinguish between the two. So then the question becomes, why? Well, 85% of dogs that come in with Cushing's disease will have a pituitary dependent Cushing's disease. Of that 85% that have pituitary dependent, only 15% of those dogs will have a macroadenoma. So the vast majority of dogs that come in with Cushing's disease are going to have a pituitary microadenoma. The others that remain, the other 15% that don't have pituitary dependent, obviously have adrenal dependent, and about half of those adrenal tumors are malignant. So the question on differentiating, you can do a low dose DEX, which if it differentiates, you have your answer right there. If the low dose DEX does not differentiate between pituitary or adrenal dependent, then most people are going to an ultrasound these days. There's not a lot of high dose DEX suppression tests, although we do still occasionally get a high dose DEX suppression test calls at the clinic. But most folks at the call center, most folks are doing an ultrasound. It gets to be a little bit of a question of what is the pet owner going to do with that information. So if the pet owner is not going to pursue an adrenalectomy, then they maybe need to use their resources towards treatment and monitoring. If they're going to use that ultrasound and the adrenal tumor to know my dog's got an adrenal tumor, we're not going to operate, but we know at least what the future holds and what to expect. Some pet owners will want to know that. And then some will want to know everything, and they'll want to pursue adrenalectomy and whatever other aftercare the dog may or may not need. So it does kind of boil down to what are the goals of differentiating. And I think there are a number of folks that aren't going to want to differentiate because they're not going to pursue an adrenalectomy. And if that's the case, they can use trilostane and it will work just as well as if they had any other type of Cushing's disease.
Yeah, even as an academic, I agree with that. I mean, if you don't, whereas when we were using mitotane, you really need to know the difference between adrenal and pituitary, like significantly affected your protocol. With trilostane, maybe some of them that are adrenal may require more, but I still have this starting point, the same starting point. And just because the owner doesn't do an ultrasound now also doesn't mean they couldn't do it later if they wanted to. We had a student's dog who had Cushing's and we were treating with trilostane, and then it got a little bit more complicated down the road. So the owner decided to go with doing an ultrasound, and we found an adrenal tumor and we did an adrenalectomy. So the fact that we hadn't done one at the beginning wasn't a big deal. At the beginning, he wasn't super motivated to do an adrenalectomy, but later on he was. So it's not something that's a now or never type thing. I always tell people that there's a little part of my endocrine soul that dies every single time we treat an animal without knowing whether it's adrenal pituitary, but I will actually get over that, but people's pocketbooks won't. And I would much rather dogs be treated for their Cushing's and have a better quality of life than if it's an option between that or paying for additional testing.
Anybody that's been in practice for a little while has probably seen that case where we spend $1,500 working up the dog, and then we say, great, now here's this medicine, and the owners can't afford it. They spent it all on diagnostics. So the ultrasound is kind of one of those great to have, not always completely necessary type deals.
That's such a good point that, yeah, we have to really make sure we understand what the resources look like, and we're using those in a way that's going to be the most effective to manage the patient. You mentioned with adrenal tumors, sometimes they require more trilostane compared to pituitary tumors. And I want to know your thoughts on dosing, because I feel like I've seen, I agree with when I use twice daily dosing, they do tend to regulate in my hands, sometimes a little bit quicker. But I can think of one patient in particular. We just kept increasing. She's pituitary dependent. She's not adrenal dependent. And I mean, I think we were up to like 6-7 mg per kg, and Patty's making a face like, yeah, it's fine, no big deal. So I'm curious to know, it felt like a lot to me. How do we think about dosing? Is there a maximum dose for trilostane?
Not really, to be honest. There's not. When trilostane came out in Europe years ago, 20 years ago now, or even more, it was introduced at only 30 or 60 milligram capsules. I can't even remember which one it was. But the point is, those size capsules were for every single dog. So even if you had a little Chihuahua or Yorkie that was 2 or 3 kgs, they were going to get the 30 or the 60 milligrams. So we're talking 10 mg per kg or 20 mg per kg. So back then, these dogs were getting those higher doses, and they seemed to be okay in general. So I don't know. I feel like most dogs that I see can get clinically controlled with somewhere between 1 and 3 mg per kg BID. But then there are others where you just keep going up. I mean, there's a point where you keep going up and you're like, man, that's really, really expensive. What other options do we have? But it may be interesting to look at their pituitary, make sure they don't have an adrenal mass, that type of stuff.
This is a very common question that we get in our call center at DECRA about minimum dosing, maximum dosing. We will see it at both ends of the spectrum. Painting with a very broad brush, small dogs tend to need more trilostane and have an increased need over time. Large dogs tend to need less trilostane and have less of a need over time. So if I've got a little 10-pound Maltese that's on 60 milligrams a day, I'm not too surprised. If I've got a 100-pound Labrador that's on 180 milligrams a day, I'm going to be much more surprised with that one. But I'm not going to be surprised if that 100-pound Labrador is on 5 milligrams a day. Now, that's not their initial starting dose. Their starting dose is that 1 milligram per pound. Some people will divide it. Some people will give it all once daily. All of that's fine. But I always tell people when they call in and talk to us, after that initial dose, they will choose their trilostane dose on a mg per kg basis based on their astrologic sign, the tide tables, and the moon phase. There is no rhyme or reason to what mg per kg dose they will settle in at. A lot of these guys will settle in at a reasonable dose. And after a few months, tide tables will change and they'll just decide I need more or less. And that's why monitoring can be so important. After you do the starting dose, I don't put any thought into their mg per kg dosing whatsoever.
That's really helpful because I have to admit I was panicking a little. I'm like, this is so much. That's good to know. I didn't realize that we had these little tiny dogs on 60 milligrams of trilostane, which, I mean, that seems like so much, and that the majority were responding. And I think I'm going to just hear your voice in my head, Alex, when I'm dosing these and having to go up of they're gonna pick their dose based on, nothing that we can map. It's going to be up to them how much they end up needing. But certainly it's good to know too with the larger dogs that if we are having to creep up, maybe we need to look for comorbidities. The dog I was just talking about where we did have to continue to increase her trilostane dose did end up diabetic as a shock to no one. And we got her under control, and I just did a stim on her a couple of weeks ago, and her cortisol levels have never looked better. I was so excited we finally got her regulated. But thinking about these doses and that we can end up going up and up and up, I'm curious about adverse drug reactions. Are there reactions that we should be aware of as we are creeping up and up with that dose? And are they dose dependent?
Yeah, that's a great question. In terms of the types of calls that we get at our call center, a lot of them are going to come, should I expect this with trilostane rather than trilostane caused this, that, or the other? And back to the dosing, and when it initially launched, it was 60 milligrams, but now there's 10s, 20s, 30s, 60s, 120s. So there's more to come when it comes to trilostane, milligram sizes, and all that sort of stuff as well. In terms of things that I tend to watch out for, one of the big things that I watch out for in the initial first couple of weeks is what's called cortisol withdrawal syndrome. So these dogs have been cruising around with these abnormally high circulating cortisol levels for probably a few months in most cases, maybe longer. And their body is slowly kind of acclimated to this abnormally high level of cortisol. And so when we add in trilostane and start to bring that down, they will start to react as if they've become oversuppressed or Addisonian. So it's usually within the first couple of doses, they will start to have lethargy, vomiting, diarrhea, not wanting to eat. They will look very much like an oversuppressed dog. Treatment for those guys is pretty straightforward. You can give them symptomatic care. While it is nice to do monitoring, most of the time we don't necessarily need to do it if it's that first couple of days, because it's pretty unlikely that we get adrenal necrosis after a few doses of trilostane. And most of them recover within a day or two just by simply stopping the trilostane and a little bit of supportive care. Then when it's time to come back around and the dog is feeling really well again, let's do a 50% dose reduction and slowly work them up to what may be their more appropriate dose. Those are going to be the most common things that we see in the first couple of weeks. Unfortunately, if you look at the kinds of dogs that have Cushing's disease, they're often older. And so a lot of the quote unquote side effects that we will see associated with trilostane are age-related because they're on it for a couple of years. So they're the sort of things that we'll see is heart murmur is on the package insert as an expected adverse drug reaction. How did it get there? It got there because small breed dogs take a lot of Vetoryl, and small breed dogs are prone to developing heart murmurs. It's not because trilostane causes heart murmur. So some of it can be a little confusing looking at the package insert on that kind of stuff. But one of the big ones that we want to be on the watch out for long term is there is a risk of adrenal necrosis with trilostane. It can happen kind of without warning and at any time. Monitoring is very important in terms of lowering that risk and catching these guys before they really truthfully don't have enough adrenal reserve. And it's not really well understood why it happens, but the current thought is that trilostane blocks a hormone in the cortisol cascade, but it doesn't address the underlying increases in ACTH that these guys have. So they're getting this, their adrenal glands are constantly being told to produce more and more cortisol, and they're just at a certain point, they can't keep up and they necrose. So that's kind of the current thought. There's actually a pretty good paper that came out that showed the majority of those dogs do recover. The longer that they require DOCP or prednisone, the less optimistic I get. And in my experience, once they require DOCP, they usually are going to require DOCP and prednisone for the rest of their life. There's maybe one or two I can think of that I've consulted on that did recover. Most of these guys, if you catch them with a low stim, they're going to recover. It might take many months before they show signs of Cushing's disease again. That's okay. Just stay there. Be happy that we don't need trilostane and monitoring. But that's going to be the biggest risk is oversuppression. And unfortunately, it does happen a lot of times without warning, even when we're doing everything right. It's very rare, though.
That was gonna be my next question and you may have said this already of how often it occurs. What is there a percentage of dogs where we see that?
I don't have a percentage offhand of dogs that go on to develop iatrogenic Addisons. That one's going to be extremely rare. In terms of dogs that are quote unquote oversuppressed or have a low stim when they're clinically normal, that's going to be relatively common and something to be on the watch out for. Again, treatment for those guys, super straightforward. Just stop the trilostane, give those guys a couple of weeks off trilostane. The package insert does talk about rechecking a stim and not restarting trilostane until the post is greater than 9.1, but wait for clinical signs of Cushing's disease to return for sure before restarting trilostane, and then do it at a 50% dose reduction, most of those guys.
Yeah, there was actually a study from, I just had to look it up, 2017 that showed like 15% of dogs being treated with trilostane with the first 2 years have signs of oversuppression at some point, and then 25% over 4 years. So it's not super uncommon, but I agree that I just don't see adrenal necrosis often anymore at all. I'm a little bit more paranoid in the first few days because I've seen like years ago a couple of them that did have problems the first couple days. So, but I agree. I check a baseline cortisol on them. It's fine. I'm like, well, I told them to stop the med, so I can't really figure out what the stim was. Stop it for a few days and start it again. What's super interesting is I've had the exact same experience as you have with feeling like once they have to go on DOCP, they're probably Addisonian forever. What's super interesting is the study I'm talking about, it actually did not show that once they went on DOCP, it was consistent. So I don't know. I feel like that's my anecdotal evidence. A study disagreed with us, but I don't know really what to do with that.
I feel like it's a good marker to be aware of, though, to say, if we do need to start DOCP, maybe a client communication point to say, we're going to watch these guys a little bit closer, and this may be a little bit more of a long-term thing. We can say based on anecdotal information.
I agree. What I do love, though, is the same ones Alex was talking about, where they go Addisonian very briefly. So not really Addisonian. They show signs of cortisol oversuppression. You stop them. You stop the trilostane, and then you watch them. And I've had some that literally never, ever require trilostane. Again, I'll stim them, and they stim to like 7 microgram per deciliter. And I look at the dog. I'm like, well, you don't seem to have Cushing's anymore. And we're like, how do we do that consistently? I wish I knew because it's great. The owners are super happy with those.
Absolutely. Absolutely. That would be ideal. If only we could repeat those results in a reliable way. That'd be great.
Yes.
And somehow, I'm very proud of us. I think we managed to hit all of our talking points and not go incredibly over time. So much great information here. I know I learned a lot. And I mean, I feel like I always do when we talk about Cushing's disease. There's just so much to, I don't know, adrenal disease in general. It can just have so many different variations. So thank you to both of you for joining me. Are there any final thoughts you want to share?
I guess we didn't really get to monitoring too much with either cortisols or ACTH stimulation tests, but I would say the final things about monitoring dogs with Cushing's is remember their primary goals are to treat the clinical signs and not to oversuppress them. So for me, I'm perfectly happy if the dog is clinically controlled and their cortisols aren't low, meaning they're oversuppressed, whether you're doing a pre-pill cortisol or you're doing an ACTH stimulation test. There are obviously a lot of nuances there, but I think if people remember, treat the clinical signs and don't oversuppress them, I think we're good.
I love that. Treat the patient, not the number.
Yeah, it's a clinical diagnosis with few exceptions. You have to walk in and kind of look at the dog and think, boy, I wonder if this dog has Cushing's disease, and then pursue diagnosis. And do not ignore monitoring. There's lots of different ways to do monitoring, and in our call center, we're happy to talk you through the pros and cons of each. It's endocrine testing, and whenever there's an endocrine test and there's more than one option, that tells you that none of them are perfect. So we will help you talk through what's best for your patient and your practice. We're more than happy to talk about monitoring.
I feel like all of that really gives us the freedom as practitioners to know that, like you said, there is no one straightforward way to diagnose, treat, these patients, that all these cases are going to be different. So if we have one that's stumping us, then that's normal. That's okay. We can make a phone call and get some help.
Absolutely.
Well, thank you to both of you. This was a great talk. Thank you to everyone tuning in. I was shocked. We actually didn't go overtime quite as much as I thought we were going to. I was sure this was going to end up having to be divided into 2 episodes because it was just such a great conversation and there's so much to say. And these two are just such wonderful sources of information. So Dr. Lathan, Dr. Betson, thank you so much for joining me. It was such a great conversation. A huge thank you to DECRA for making this episode possible. And of course, thank you to all of you out there listening. I hope you enjoyed it as much as I did. If you did enjoy this episode, please leave us a 5-star review wherever you get your podcast to help other veterinary professionals like you find this and other great content we try to put out there. If you want to hear more episodes, you can click on the Education tab on the Vetfolio website or find us wherever you get your podcasts. Of course, we would love to hear your input on this talk as well as ideas for topics you'd like to hear from us in the future, so feel free to reach out to me at dvm@vetfolio.com. We can also connect on Facebook at Dr. Cassie DVM, or you can find me on Instagram at dr.cassie.dvm. And remember, if one animal is better off because of you today, it's a great day.